To Talk 3, Organ System Toxicology, focusing on the liver, kidneys, and GI tract. These three organ systems are at the front line of toxic exposures. The GI tract is often the first point of contact. The liver is the primary metabolic engine, and therefore frequently the target of metabolite-mediated toxicity. The kidneys are the final filtration system and are exposed to high concentrations of excreted toxins. By the end of this talk, you'll be able to recognize the clinical syndrome associated with hepatotoxicity, nephrotoxicity, and GI toxicosis, understand the common toxins that target each system, and think through a logical diagnostic and therapeutic approach. Let's think about why these three organ systems are so commonly affected by toxins. The GI tract is ground zero for ingested toxins. It has a huge surface area for absorption and is lined with rapidly dividing cells, which are inherently more vulnerable to cytotoxic damage than less active cells. Many toxins have direct corrosive, irritant, or cytotoxic effects on the GI mucosa before they're even absorbed. This gives you clinical signs, vomiting, diarrhea, abdominal pain, that are your first warning signals. The liver sits downstream of the GI tract. All absorbed substances from the gut pass through portal circulation to the liver before reaching systemic circulation. That's the first pass effect we discussed in Talk 2. The liver is incredibly metabolically active. It's handling a constant stream of xenobiotics. And because bioactivation happens here, the liver creates its own toxic insults. Reactive metabolites generated during phase 1 metabolism can directly damage hepatocytes. The kidneys are the end-stage filter. They receive about 20% of cardiac output, and they concentrate substances during the process of making urine. So anything circulating in blood reaches the kidney at high concentration. Tubular cells, particularly proximal tubular cells, are highly metabolically active and therefore vulnerable. Certain toxins are directly nephrotoxic. Others become nephrotoxic as metabolites accumulate in tubular cells. The overlap is clinically important. Many toxic exposures hit all three systems to varying degrees. Ethylene glycol, for example, causes GI signs first, then acute renal failure. NSAIDs cause GI injury, hepatotoxicity, and nephrotoxicity. Think in systems, not silos. Get into hepatotoxicity. The liver has an enormous functional reserve. You can lose 70 to 80% of hepatic function before overt clinical signs of failure appear. This is actually a double-edged sword clinically. By the time you see jaundice, coagulopathy, or hepatic encephalopathy, there is already massive hepatic compromise. This means aggressive early monitoring is essential when hepatotoxic exposure is suspected. Look at the ALT chart. At time 0, liver values are normal. At 6 hours, a subtle rise. By 24 hours, massively elevated. Peaked at 48 hours. This pattern of delayed elevation followed by a plateau and gradual decline is classic for many hepatotoxic events. Common hepatotoxins you must know. Acetaminophen, as we discussed, bioactivated to NAPK, which depletes glutathione and destroys hepatocytes, worse in cats. Xylitol causes hypoglycemia and hepatocellular necrosis in dogs, possibly through mitochondrial disruption. Blue-green algae, cyanobacteria, Microsystem is a cyclic peptide that inhibits protein phosphatases, disrupts cytoskeletal integrity in hepatocytes, leading to centrolobular necrosis, rapid and often fatal. Amatoxins from Amanita mushrooms inhibit RNA polymerase II, leading to cells can't transcribe proteins, leading to hepatocellular necrosis and renal injury. Cycad palms. Cycasin is metabolized by gut bacteria to methyl-methanol, a potent hepatotoxin and carcinogen. Aflatoxins. Fungal toxins from aspergillus on contaminated grain or pet food. Centrolobular necrosis, chronic exposure, cholangiohepatitis, hepatocellular carcinoma. Treatment support. The liver. N-acetylcysteine replenishes glutathione. It's your go-to for oxidative hepatic injury. Vitamin K for coagulopathy. Silymarin milk thistle has hepatoprotective properties and is often included in supportive care. Critically, do not give drugs metabolized hepatically at standard doses when hepatic function is compromised. Toxicity is one of the most clinically significant toxicologic emergencies in small animal medicine. Let me start with ethylene glycol, antifreeze. This is the textbook nephrotoxin, and it kills a lot of pets every year. The mechanism has 3 stages. First, ethylene glycol is absorbed rapidly and causes initial CNS signs. The animal appears drunk, ataxic, disoriented. Owners sometimes miss this or think the animal just ate something weird. This phase lasts a few hours. Then a latent period. The animal seems to improve, but this is deceptive. The liver is busily metabolizing ethylene glycol, first to glycolaldehyde, then glycolate, then oxalate. Oxalate combines with calcium to form calcium oxalate crystals, which deposit in renal tubular cells. Tubular cells die 12 to 72 hours after ingestion. Acute oliguric or inuric renal failure develops. At this point, without aggressive intervention, ideally dialysis, the prognosis is grave. The antidote, fomepizole, 4-methylpyrazole, 4-MP, blocks the enzyme alcohol dehydrogenase, which is responsible for metabolizing ethylene glycol into its toxic metabolites. If given early, before significant metabolism has occurred, it is dramatically effective. Dogs within 8 to 12 hours. Cats must be treated within 3 hours. Cats metabolize ethylene glycol faster. In a pinch, ethanol works by competing for the same enzyme. It's old school, but still used in some settings. Lily toxicosis in cats. I cannot overstate this. Hemerocallis and lilium species, daylilies, Easter lilies, tiger lilies, stargazer lilies are uniquely profoundly nephrotoxic to cats. The mechanism is still not fully characterized, but the result is severe proximal tubular necrosis and rapid progression to complete renal failure. Even a small nibble on a leaf or a small amount of pollen on the coat that is then groomed off can be fatal. Treatment. Aggressive diuresis within 18 hours can be effective. After that, dialysis or euthanasia. Grapes and raisins in dogs. The mechanism remains incompletely understood. Tartaric acid is the current leading suspect. Not all dogs are effective, and there's no clear dose response. This unpredictability is what makes any grape or raisin exposure a cause for concern. Toxicology covers 2 distinct scenarios that you need to keep straight. First, toxins that directly damage the GI tract. Caustics, acids and alkalis, burn. Acids cause coagulative necrosis. Alkalis cause liquefactive necrosis, which tends to penetrate deeper. You see hypersalivation, pawing at the face, retching, pain. The key management point: do not induce emesis. Vomiting a caustic brings it back up through the esophagus. You cause additional damage. Do not give activated charcoal. It won't bind caustics, and the granules can make endoscopic assessment impossible. Instead, dilute with water or milk and seek endoscopic evaluation. Second, toxins that cause GI signs as part of systemic toxicity. Organophosphates cause vomiting and diarrhea through cholinergic hyperstimulation. NSAIDs disrupt the protective prostaglandin layer in the gastric mucosa, leading to ulceration and hemorrhagic gastroenteritis. Lead poisoning causes vomiting, abdominal pain, and eventually neurological signs. The activated charcoal slide is clinically important. Activated charcoal works through adsorption. The toxin sticks to the charcoal surface, and both are then excreted in feces. It's effective for most organic toxin, but it does not bind heavy metals, ethylene glycol, alcohol, or xylitol, and caustics are an absolute contraindication. The sorbitol carrier in many formulations causes osmotic diarrhea, great for preventing reabsorption, but can cause significant electrolyte shifts, particularly in cats. Use plain activated charcoal in cats or dilute it. Ileus is a serious complication of any severe GI insult. It allows bacterial translocation across the damaged mucosa, which can lead to systemic inflammatory response and sepsis. Monitor for it. Toxic exposures rarely stay neatly in one organ system. Let me walk through this table. NSAIDs. GI ulceration is the most common toxicosis. The mechanism is prostaglandin inhibition. Prostaglandins normally protect the gastric mucosa, but NSAIDs also reduce afferent renal arterial tone. In a patient who is already hypovolemic or hypotensive, this can precipitate acute renal failure. Hepatotoxicity is less common, but does occur, particularly with certain NSAIDs. Ethylene glycol, GI signs first, vomiting within minutes to hours. The liver converts ethylene glycol to toxic metabolites, but is not itself a major target. The kidney is where the damage accumulates. Oxalate crystals destroy tubular cells. Acetaminophen in cats. Vomiting and anorexia early. Hepatocellular necrosis is the primary injury from NAPKI, but methemoglobinemia is actually the more immediately life-threatening issue in cats. Acetaminophen oxidizes hemoglobin iron, creating methemoglobin, which can't carry oxygen. You'll see the characteristic muddy brown blood. Renal injury can also occur, particularly if hepatic failure ensues. Amanita mushrooms. These contain amatoxins, alpha-amanitin being the primary culprit. The clinical course is biphasic. First, severe GI signs within hours, vomiting, profuse diarrhea, abdominal cramps. Then, an apparent improvement. Then, 2 to 4 days later, fulminant hepatic failure as amatoxin inhibits RNA polymerase II and shuts down protein synthesis in hepatocytes. Secondary renal failure follows hepatic failure. This biphasic pattern is diagnostically important. The improvement is false reassurance. Heavy metals, lead, arsenic, and mercury all cause GI, hepatic, and renal toxicity to varying degrees. Lead is particularly concerning in young animals, which absorb it far more efficiently than adults.